All right, thanks for joining us for the Blair Upper Cervical Podcast. I'm doing a solo show today. We're missing Dr. Kevin Pekka, my co-host on this episode, but we're going to forge on anyway, and I want to introduce you to Dr. Noah Kaplan. Many of you know Dr. Kaplan from the upper cervical community. He's a diplomate in craniocervical junction procedures. He's a Blair chiropractor and an awesome guy. So really excited to have you on the show today, Doc. And for those that might be less familiar with you, give us an idea of your background, how you got into chiropractic, and what led you to the Blair work.
Yeah, thanks, John. Good to be with you. Thanks for having me on. So I don't know if you have this experience, but you live long enough and there's certain kind of events that are significant enough in life that kind of split your life between before and after, right? I think a couple of those, two in particular really shaped my chiropractic journey. The first was, I was at University of Colorado in Boulder, doing undergrad my freshman year, and I was playing on the soccer team and I hurt my knee. And that kind of sent me on just a divergent path. Totally changed my life because it just became so complicated. I had, ended up having 4 surgeries, was off and on crutches. Long story, but while I was rehabbing my knee, I ended up injuring my back. I actually herniated my L5-S1 disc. Spent literally, 2 years just in bad shape, where I had to leave Colorado. It's kind of flat on my back for a couple of years, just trying to figure out what I was going to do next. Eventually, I got things together, and I ended up, graduating college and went to work in San Francisco at a tech sales company, and was doing really well. I was shooting up the corporate ladder. I was there for about 3 years and living and working in San Francisco, and it was great. I met my wife at that company and a lot of good friends, but I was just having chronic back pain, sitting at a computer, and I just realized that the 40-hour work week in front of a desk is just not a sustainable thing for me, or at least it wasn't at the time, with the back pain that I was having. So I, started interviewing some chiropractors. I was under chiropractic care at the time, and I had seen probably, a half dozen chiropractors at that point. So I started interviewing them. I started, trying different chiropractors just with my own back pain, and decided to make the change. And so I ended up, I had to just go backwards. I went back and had to, wait tables. I went from like a very high paying job, had to wait tables, go back to get my prerequisites, like a fast track prerequisite, because I was a business major, so I had to get all the science. I ended up starting at Life West in fall 2007. And first quarter was Dr. Sean Dill's Philosophy 1 class. And so you may have heard of this. It's just a notorious class, very polarizing, but also very stimulating. I mean, probably 85% of the people just didn't like him, but 100% of the people were very engaged and very interested. And everyone knew he did upper cervical, and he would kind of weave in some upper cervical concepts. And it was just very stimulating for me. It was totally different from what I thought chiropractic was. And then between, first and second quarter, event number 2 happened, which was, my brother passed away unexpectedly. And, that was a big thing for me. It kind of turned my world upside down. And I just, the first thought I had at the time was to quit. I mean, I thought, I'm only a quarter into this. I'm just gonna kind of, do something else. This is too much. But I decided to kind of just, let's just give it one more quarter. I'm just gonna put kind of one foot, in front of the other and take it a quarter at a time. And I just continued, and it was actually therapeutic at the time because no one at school knew what was going on, or what had happened. So there was a sense of anonymity with that I think was good for me, and I can kind of focus on school. And then by third quarter, I got under upper cervical care for the first time, and it was the only thing that actually changed my low back pain. for more than 2 days at a time. You know, I felt my entire pelvis untwist, just with a C1 adjustment. And once you feel that, once you feel it happen in your body, then it works. And so that was the experience with me. And then that same quarter, I actually went to the upper cervical evolution in Nashville. And that was huge. I mean, just incredible speakers. Those two things, just, I knew from then on, okay, I'm all in. This is going to be my path, and that was it from there.
I think it's interesting, with us in chiropractic in general, but specifically in upper cervical, I don't know that there are too many other types of healthcare providers that have that experience as a patient throughout their life, as well as being a practitioner. I mean, most upper cervical docs have had an experience like that kind of, was one of those inflection points like you're talking about. And I don't know too many dentists that had a feeling that changed their life and set them on a career path to be a dentist. So I think in that way, we have this relatability to patients that is hard to replicate in other settings, that I think is potentially even therapeutic, in value, and that we can connect with them on that level. So man, everyone that we talk to has an interesting story like that. And I think it's not something you have to have, as a patient to be a great upper cervical doc, but it is a common thread, through there. So explain for folks that are unfamiliar with the upper cervical evolution, what that was at the time. Give us an idea of sort of the techniques and the folks that were represented there, and how you sort of navigated through techniques into finding your way to the Blair model.
Yeah, so at the time, I believe this was maybe the second or third evolution conference. This must have been 2008. And so this was, a movement through, upper cervical health, upper cervical healthcare, that Dr. Drury, Dr. Vanyo started, that was I mean, I don't know the history before that, but it really was one of the first of its kind to bring all techniques together and kind of create one upper cervical message, which was great. And I think everyone was really on board with that. And I think it was refreshing for a lot of people who had spent a lot of their careers, some of these OG docs who spent their whole careers, in their technique box. And now there was this movement happening that everyone was coming together and uniting on a common message. And that was really cool for me. And actually, I will say Life West at the time I was very fortunate to be at Life West because it was very upper cervical friendly. It was a great place to learn upper cervical. We had a upper cervical systems class at the time where for 2 weeks, one of the major technique groups would come in. So, Stan Pierce would come in, Michael Zabellin and Nuka would come in, and for 2 weeks, they would teach us basically kind of the basics of that technique. And that's almost like a precursor to, the diplomate program.
Right.
But at the time, it was really cool. I mean, everyone had to take it. So, maybe 90% of the class wasn't very interested in it, but I was just eating it up. And I remember the Blair doctor was Dr. Darren White. So he came in, he spoke about Blair. I was really into knee chest, at the time. And he was smart enough to know that, most people are not really interested in learning about Blair in that class because it was a mandatory class. So what he would do is he would teach the first hour on the Blair technique, and then he would teach the second hour on, a business book that he was reading at the time, which was really cool. I mean, so much great information, I think, that everyone took from that. And a lot of my colleagues at the time, who I was doing knee chest work with, have actually gone on to become great Blair chiropractors, like we were talking about before. Rashay Bell, Michael Beebe, Tyler Evans, Ryan Lawler, Joe Ivey. These were all my colleagues at the time. They were smart enough to get into Blair earlier than I was. I had to take my time with it. But we were all, a lot of us kind of started out with knee chest, and then they actually found the Blair work pretty quickly, and they've gone on to do really well.
That's awesome. And there will be students that are listening to this that can relate to being in that setting where you're just bombarded with folks that are promising, results and have different technique systems that they're bringing to the table. And it can be confusing because there's almost like an identity crisis that happens as a student as you kind of filter into your different camps.
Yeah.
So what advice would you give to students that are kind of in that process of evaluating these different procedures and trying to figure out where they fit and what they want to focus in on, during that time in your sort of curriculum?
Yeah, I mean, I think it has to be what makes the most sense to you. I think some people just fall into what's most available to them. Whether it's like a doctor on campus that has a big influence, where they can get the training that they want. But you really have to, if you're into upper cervical, I think it's important to kind of at least have a baseline understanding of the different techniques and the orthogonal model versus the articular model, kind of what makes sense to you, and then go from there.
Yeah, 100%. I know that I went to school as a totally clean slate. I didn't know anything about chiropractic in general, so I was just eating it all up, and it was fascinating. But there were always, for me at least, there were always these holes I could poke in different technique systems. Well, it doesn't satisfy this, it doesn't meet that criteria, and
Yeah.
including some of the other upper cervical approaches I learned. But when I took Blair with Dr. Herman there at Life University, it was like I couldn't find holes to poke in it. It satisfied so many different things for me. It was congruent with our philosophy. Scientifically, it was very well, established. The art of it, was in line with the science and the philosophy. And so, for me, it checked a lot of boxes. So, yeah, for students, I mean, you've got to kind of develop your priorities within chiropractic, what your values are, and then find the system that allows you to express those values and get phenomenal results and deliver on the philosophy through the science and the art. And for a lot of us, Blair was just the thing that, brought all those things together. And it's common to, in these interviews and conversations we've got the spectrum, right? Folks that started out in full spine practice and transitioned as a DC, folks
Yeah.
that went into school that they knew that all they wanted to do was Blair upper cervical the whole way through, and everything in between. So there is a journey to it, and there are definitely those inflection points like you mentioned. So I'd say don't beat yourself up if you don't feel confident in what you want to do yet.
Yeah.
I didn't get into Blair until 13th quarter in school, and I had pretty much made up my mind on how I thought I'd practice, and that really flipped the script on me. And though I wouldn't recommend doing it this way, I've told a handful of students my first Blair patient was my first patient in the practice that I opened after school. So if you have a system, that is sound and solid, you can at least rely on the system to get good results without having to reinvent the wheel and, apply too much guesswork. So don't freak out if you're not quite there in your technique evolution. There's definitely good resources. Dr. Kaplan is one of them that I hope you guys navigate, through that sort of journey. But are there any specific points as you're thinking about, what for you in the Blair work sort of help to make the transition away from a knee chest model? Are there specific things that come to mind that really kind of grabbed you?
Yeah, for sure. I mean, I think that I think it kind of developed with, the cone beam was a big part of it. And just, I think that proves more than anything, just how the Atlas moves and how correct, the Blair model is with
Yeah.
that. I mean, one of the things that I think, every other upper cervical technique misses to some extent is that Atlas does not move in a true lateral direction. It just doesn't happen. It can't with the shape of the condyles, with the asymmetry. It just doesn't work that way. And so seeing that on the cone beam, was really significant for me. And then going through the diplomate program. I mean, so to back up, I mean, I came out of school, I had done a couple different knee chest trainings in school, and kind of as I was coming out, I joined a good friend and colleague of mine, Dr. Ian Davis Tremaine, in the North Bay. And I was working in his office right out of school for about 15 months. We developed a knee chest training program called the Upper Cervical Revolution that still exists today. I kind of stepped away from it once I started having kids and didn't have as much time to devote to it. But I already had basically the systems in place on how to treat patients, scripts, stuff like that. And so for me, it actually was fairly easy to just, make a switch with the technique at the time. I opened my practice in 2012, so I've been in my own practice for about 9 years, and I switched to Blair almost exactly 3 years ago. And that was the same time that I got the cone beam in the office, which I think is the same model that you have, right? The CareStream.
Yep. Yeah, we use a CareStream 9300 premium. A lot
Yeah.
of different options out there, really good quality machines available, for all different sort of makes and models. But yeah, it's been
Yeah.
great.
Yeah. So, I mean, I think there's a lot that went into that. One of it was, when I think about the knee chest adjustment, and I think about anterior listings, right? So ASR, ASL. If you're contacting, the posterior arch, and you're talking about the articulation between the occiput, and C1. I don't know how you can really get that anteriority out, And so that was one of the big things I was struggling with is if it's truly an ASR, if it's moving it like we think it is, according to the Blair model, how do we get that anteriority out, from a posterior angle, right? Or a posterior contact point. So that was one of the things that I think I was stuck with. And understanding the Blair anterior adjustment with the torque and how you're unlocking that joint, that was a big thing, I think, for me.
Yeah, no, you and I have talked about in the past the use of thermography and just the clinical utility and the importance of having that as sort of a foundational part of your assessment. That's obviously something they really focus heavily on in the knee chest realm, more
Yeah.
so than the leg checks and some of the other tools that we use in the Blair work. So you at least had a very firm foundation and analysis and understanding, am I clearing these patients? I don't know, with this type of approach, are we seeing the results that we expect? Are they holding as long as we'd like? So there's a clinical context behind that helps you, with those two techniques specifically to be able to compare outcomes. So we don't want to get into the comparing techniques game, but for you, as a clinician, you had a system that, was sort of reproducible across techniques, and you could appraise the outcomes and, make your decisions based on that.
Yeah, and I've never been, a lot of knee chest docs, or I guess upper cervical docs in general, they have one main objective criteria, to determine whether someone's subluxated. For me, I've never liked having just one. So, a lot of knee chest docs will just use thermography. I just was never comfortable with that, because there's variables that could affect the thermography. Some people are more, thermosensitive than others, right? It's not always practical to have people come in and, pre-rest for 30 minutes or, there's lots of things that go into that. But so I was always doing, supine leg checks and thermography, even when I was doing knee chest. I even got to the point where, the 3-view knee chest analysis on X-ray was just not enough for me. So I was adding a nasium view. So I do like the APOM, the lateral, the base posterior, and then I added an nasium view. So I had a 4-view analysis. And so that, I was kind of transitioning. I wanted more information. I felt like the knee chest analysis was, the X-ray analysis was, I think, the weak point. And so, once the cone beam came along, I thought that was, that really made sense to me.
Yeah, it's amazing. I remember seeing that in that 13th quarter Blair elective. Dr. Herman had showed us some slides with cervical CBCTs on it. And I thought, what in the world is that? Why have I not seen this up to this point? And I remember sitting there thinking, I don't know what it takes, but I'm going to get one of those. I'm going to have that in my office, because it just has to be, if you're going to do imaging, if you're going to, assess the subluxation and its misalignment parameters with imaging, then it just makes sense to have the best quality imaging to get the best information. But it puts you in an interesting position where you need to test some assumptions. Then as the imaging gets better, you've got to, look at your technique through, a clearer lens. And what you mentioned earlier about the Blair method of, calculating misalignments and such being not tested and confirmed, but just validated through the use of advanced imaging like CBCT. It just blows my mind that he was able to, in the late 50s, start to conceptualize and test these concepts with the tools and the information that he had available at the time, where 50 years later, we're saying, yeah, he was right. It's actually astounding. And I appreciate all the work that the forerunners have done to get us to a point where, we can take an 11-second scan, spend our time analyzing it, and just be that much closer to a better outcome for the patient.
Yeah, and there's so much room to grow too. I think that's one of the advantages that Blair has with the articular model, we're not just beholden to C1, like a lot of the orthogonal models are, where they're only really accessing C1. We're looking at the entire upper neck. And I think there's so much room to grow because Blair is so much more dynamic, than the other techniques out there. And then with the cone beam, like you said, this may open opportunities for us to really test, how well these adjustments are working, how the segments are moving. I mean, we just have so much more information that I think it just opens up an entire world for us.
Yeah, and I know the Blair Society definitely has some research agenda topics related to some of these things, and we're going to be using cone beam CTs to help flesh out some of those questions. So definitely some exciting things on the horizon, and I'm really looking forward to participate in that and just continue to see what we can develop. But you mentioned earlier the Upper Cervical Council through
Yeah.
the ICA has a diplomate in craniocervical junction procedures, the Upper Cervical Diplomate program, which you've completed. So
Yes.
you've received your DCCJP. Explain why you thought it was important to get into that particular program and maybe some takeaways that you learned from your time there. And that's, I understand, like a 3-year program.
Yeah, it's about 3 years. And yeah, I just, I feel like we should be the best that we can be. I mean, we are specialists, which is great, but it comes, it brings with us a responsibility to know everything we can about the craniocervical junction. At the time, one of my biggest mentors is Dr. Jeff Schulten, who is a NUCA doc, but he's been the president of the council and very active in the upper cervical community. So he was my coach at the time that I was kind of getting into the diplomate program, and he was a big influence on why I did it. And he had gone through it himself, and so I kind of had an idea of what I was getting into. And just, there's stuff that we can learn from other techniques. Blair does not have all the answers, nor does any other technique. And that's why other techniques exist, because there's not one technique that is 100% for every patient. Certain people respond to different things. Certain concepts are, orthogonal concepts, like I'll utilize in my practice, when I'm analyzing people. It's all just part of the picture. And with the diplomate, it's not just technique. I mean, that's probably maybe a third of it, where you kind of learn the different techniques. I mean, you're learning about the anatomy, the neurology, you're taking, a deep dive into all of that. And then you're learning how to read MRIs. You're learning how to, all the special imaging. There's a lot on imaging, a lot with Dr. Scott Rosa, with the work he's doing, and kind of understanding patient outcomes. There's a research component to it. So, it's really, I think it's something that anyone who's really serious about this work, who's really serious about specializing, I think it's critical. And I think it just helps you in your career, especially as you're, communicating with other professionals, other health professionals, whether it's, medical doctors or neurologists or, massage therapists, whatever. I feel like, after that program, I really have a good mastery, of the upper neck. And it's amazing that, I mean, this is really the only thing that exists. I mean, it's such a unique and vital joint complex, the craniocervical junction. And the fact that we don't have specialists in that is, up until this point, is pretty crazy. I mean, we have specialists in ears and teeth and feet, yet something so important as the craniocervical junction is just, kind of overlooked. I mean, how many MRIs have you read where they don't even mention anything about, CO to C2?
Yeah,
It's like it doesn't even exist.
I know. And unfortunately, I think a lot of patients in the communities, kind of put certain doctors or professionals on a pedestal that is just holding them to a standard that's unattainable, meaning that these folks should know everything about everything. And, sometimes there are issues that are hidden in plain sight. And when you take, sort of a chiropractic functional view, you can sort of elucidate some of the things that have been holding them back that maybe a neurologist or even a neuroradiologist aren't necessarily trained to read in quite yet. So I think in
Yeah,
that way, it's sort of groundbreaking the work Dr. Harshfield, Dr. Rosa, and some of the others are doing and presenting this information in a way that gives the DC tools to be able to answer some of those questions sort of at a different level or from another perspective. And whether or not that changes drastically, what you do clinically, it's important to understand, like you said, because I think a lot of us, in the upper cervical community are technicians. We're great technicians. We're really good at following the procedures and getting great results with the steps that the techniques have established. But even working through Dr. Jeff Hanna's neuroanatomy module that the Blair Society is offering, it's just blowing the dust off of all of these concepts that we learn in school, and kind of like you said, in your upper cervical class, like sometimes you kind of gloss over it or it doesn't quite become ingrained.
right.
So even just understanding basic neurophysiology, some of the unique features of the craniocervical junction, that separate it from the lower spine in the way that we approach things. It's great for you, and knowing exactly what you're doing and how you're affecting the area. It's great to be able to explain concepts to patients beyond some of the, kind of cliche upper cervical things that we always tell folks. I've always been a little bit dissatisfied with some of that, and I want to give folks an honest but more appropriate answer.
Yeah,
And so I find that the deeper you dive in some of these things, it just blows your mind what's going on in this top 4 inches of the human body and how it impacts systemic global function. So I'm keen to do the diplomate program this next time around. I haven't committed yet, but it's something that's definitely on my radar, and I feel that like you said, with the information and the network that's within that community, it seems like a no-brainer to just insert yourself into that community.
totally, totally. And it's one of those things, where once you get into it, it just peels back layers, and you're like, God, I don't know anything. I mean, you just realize how much you don't know and how much there is to learn about this. You think right? You're proficient at the Blair technique or whatever technique you practice, and gone through school, and then it's like, holy cow, this is just
Yeah, that's
miles and miles deep here.
that conscious incompetence level that you hit so that then you can
Absolutely.
grow the next. Awesome. Is there anything directly clinically that you've changed as a result of going through the program? Are there protocols, procedures, systems that you might have adopted, to add to your clinical utility belt, as it were?
Yeah, I mean, I use the orthospinology instrument probably 10% of the time.
Hmm.
So certain cases where I don't feel like the drop adjustment is gonna be right for that patient for whatever reason, whether it's elderly, or some kids where I just, my hand's too broad of a contact. Um, and I'll use the table, kind of with some orthogonal concepts, whether I'll tilt it, or shoulder position, and kind of use the, orthogonal angles and so forth to try to get that correction. So that's one thing. And I really like the orthospinology instrument. It's far better than, activator or anything else we have, when you want to use a lighter force.
Yeah, for folks that aren't familiar with what he's referencing, I think it's called a Laney
Yeah,
KH2 instrument. It's a handheld adjusting tool that does have an excursion, so it doesn't work like an Atlas orthogonal sort of percussion wave adjustment. It does, move
right.
with varying levels of, depth, I understand. So a nice little tool to have handy when and if you need it. So I know
Yeah,
there are plenty of people that'll say I've never needed one, in all my years of practice, but it's just to know that there are things available that, might serve you.
right. And then another thing, I mean, I'm gonna get in trouble for this, but I my main test for leg check is supine. Um, because of the influence with the orthogonal. I mean, Blair's the only one that does prone. The only upper cervical technique that does prone. So supine's kind of my baseline because I'm the type of person, I mean, you and I have talked about this, where I'm not as segmental. I really want to, find the major, and I just want to know whether they're in or out in most cases. Now there are definitely cases where I need to do prills, in order to, if they have multiple misalignments, I need to figure out what needs to be adjusted or what combination needs to be adjusted. So that does happen, a certain portion of the time. But I think the supine, all the research, there's lots of research in supine leg checks in NUCA and orthospinology. They've done a really good job, I think, with inter practitioner and intra practitioner reliability studies. So that's kind of, that's what I do. So that would be another influence, I think, for sure. And then just, complex cases, I think when you just go through your basic Blair analysis, and, they're obviously, most people will fit into that category, have a good sense of how to treat them. And then there are some that are just kind of, outliers, and maybe there's car accidents or different things that totally change the normal patterns that, having some other concepts and other techniques, I think is really helpful.
Yeah, I think one of the things that comes to mind as I'm listening there is, you first want to dedicate yourself to a high level of proficiency in your technique system before you start branching out and trying to mix and mingle a little bit.
Right.
Not there's anything wrong with that, but if you don't have a firm grasp of the standard Blair procedures and how to use that in practice, you're going to end up getting yourself confused. And, I think that that's a point to underscore for students or some of the docs that, are kind of got the shiny object syndrome, and we can all be guilty of that at times where something else, seems to be more promising. So, I would anticipate that folks that are listening might want to just pump the brakes, get proficiency certified through the Blair Society, learned the procedures inside and out, learn the rationale, learn the reasons why we do the things that we do. And then from there, you've at least got a foundation for making those judgment calls if and when you need to start to, implement other types of tools.
Yeah.
So let's talk about what maybe a little bit of procedural sort of practice in your office, what a typical new patient procedure entails, what a typical office visit entails, kind of how you work folks through your program.
Yeah, so we'll do an initial exam with the cone beam, with the imaging, and one of the things actually that's a great thing I implemented recently is I don't do in-person free consults anymore. It's it's fine to do it at first when you're just starting, I think, but when you get to the point where you're really busy, it's kind of a waste of time. If they don't show up, then you've just blocked off an entire hour. So what we do is either, if you either sign up for an initial exam and we do it's 300 for us with the imaging, or you can have a free phone consult. And so that way, if they don't show up or if it's not a good candidate, I will have only spent 15 minutes on the phone, outside of my normal hours, instead of blocking out an hour where another new patient could have gotten in. So that's something that's actually been really helpful recently. But
yeah, we're talking in February 2021. So we're still living in an era where COVID-19 pandemic is affecting certain practices in different parts of the country and procedures and things like that. So it's a great workaround as well for folks that maybe don't feel so comfortable coming down just for a conversation, or to at least bridge the gap and make it a little bit more accessible for them to be introduced to the concepts to then take the next step. So that's cool, cool adaptation, especially considering the times.
Yeah. And then once we do the initial, what I do is I schedule them for 2 more visits. And it's important, I think, to take it a step at a time. You don't want them to be overwhelmed with the process. So once you see enough evidence on that initial visit, I do 2 more visits. So I'll do the first adjustment visit and then the follow-up within 2 to 5 days of that. First adjustment visit, you show them the images, you do the correction, you remeasure, make sure it worked. And then you have that follow-up already scheduled. And so once I see them for the follow-up, that'll be more of the financial, engagement. So see how they did, check them, present the plan. And for me, I always like an initial care period of 3 months. I feel congruent with that. I think that's enough time when you talk about, how tissues and ligaments remodel. I think 3 months is very reasonable, and I think, I think everyone else agrees with that in terms of my patients. I don't get a lot of pushback on that. And then reevaluate at the end of 3 months. And then I do stick with, for me, I have 2 options for that initial care period, which is You can pay monthly, or you can prepay for a 10% discount. And I'm very firm with that, because that's what's going to guarantee the results. Getting that engagement, getting that commitment from them. And then after 3 months, once I do the reevaluation process and determine if we want to continue, then it just goes to visit, and there's some different options there. But for me, that works really well. I think, I'm someone who tracks my stats very closely.
Mhm.
My conversion percentage is very high, like 95%, in terms of people I present the care plan to who sign up. Where I'm not so good is like the 9-month retention, 12-month retention. I think that's where I really need to work on. I think once people get to the point where it's like, 25 to 30 visits, I'm not so good at keeping those people engaged. So that's where I need to work on this year.
Yeah, there's a lot of different ways you can, break down and practice from a stats point of view. PVA is one that folks get very interested in, and it's kind of a unique thing within upper cervical care because we're trying to not adjust our patients, and so I
Yeah.
think we have a unique sort of way of thinking about, what that means throughout the course of the patient's lifetime, how many adjustments now we want to use to get them to a point of stability, and then monitor and maintain that adjustment over time. But it's a little bit different in that, they may go months, or years feeling well and doing well and not requiring many adjustments. And so, connecting the dots between the need to be checked, and, having that type of experience is, maybe a little bit of an additional challenge. And there are a host of other communication challenges, with patients in an upper cervical setting anyway. But how do you, let's focus on that sort of initial, 3-month treatment plan or care
Yeah.
plan that you've established. How do you set expectations for folks about where you'd like them to be at the conclusion of that initial plan?
Yeah. So what we consider a success, they have part of the reevaluation process is, they have a form they fill out where they rate their symptoms subjectively in terms of change. It's negative. The scale is -1 to +4. +4 would be symptom has totally disappeared. -1 would be it's gotten worse, right? So if we don't see 2+ or more, we don't consider that a success in terms of symptoms, right?
Sure.
There are other ways to measure success, right? Function, activities of daily living, etc. But for us, that's what we're looking for, and that's the expectation, that I set. That if we stick to the schedule in 3 months, like this is what I'm expecting. I'm not expecting you to be a finished product, at 3 months, but I want to see what I would consider what we can agree upon is significant change, you know.
Yeah.
And I think one of the things that's really important, I assume you do this too. I'm definitely a systems person, and so my first, 15 visits are scripted. Not word for word necessarily, but I have prompts that come up on my software. I have topics that I want to talk about, whether it's an exercise or whether it's, hey, let's talk about your sleep position, or hey, the magic is in the hold, not in the adjustment itself, right? Etc. So there's different things that that helps me stay on track, because there's no way you're going to remember to say everything to everyone, right? So you got to have those reminders, and so that's helpful for me too, to make sure we're hitting our benchmarks and kind of getting through that initial care period.
Yeah. When you think about not just the investment of, financial investment that someone makes in their health when they initiate that care plan, they're also making an investment of time. They're taking time out of their day, their week, to come down and to be checked and to engage in that experience. And so I think being intentional with the time and the effort that you make in communication is honoring the investment of their time. People have busy lives, and they don't necessarily need to talk to us about masks or whatever else is sort of popular in the pop culture. It's an interesting opportunity to sort of plant the seeds for some of our philosophical concepts and things that they're not going to hear anywhere else, number one. And then number two, if you can kind of anticipate, I'm sure there's a pattern to it that you recognize. Certain types of questions come up at different phases of care. So if you can kind of anticipate and be ahead of the questions that they have, it reinforces their confidence in you that you're an expert, that you're working them through this purposefully, and that you're giving them the tools to succeed rather than just trying to get them to keep coming back in. So I know
Yeah.
Dr. Forrest has a 21-day uh, uh, series of educational tools that I think is available either on the Blair website, or all you'd have to do is email them and ask for it. But it's something
Yeah.
that I have, saved on my computer, and I reference it. The patient goes to lay down, I'll take a glance at what, visit they're on and what the concept is. And same thing, it just gives you a reason to be purposeful with the interaction, and to, give them the tools to be educated and advocates for their own sort of healthcare.
Yeah, and he's the master. I mean, he is the master at education, and I have that same packet. And he lives, or he works 30 miles down the road, 25 miles down the road. So we'll get some crossover patients, or I'll get patients that come from his office, and I'm always amazed at how well educated they are.
Yeah.
I think he really has that locked in really well, and I've observed him, and he's really good at it. I mean, he's drawing diagrams, on the whiteboard, and he's, I think, he has it so memorized and so locked in that he's really effective, and I can tell that his patients get it too.
Yeah, and that's a powerful example that he's led, because he's not spending all day talking to people. I mean, he's seeing a lot of patients and doing good
Yeah.
quality work, but he's got it so succinct and so dialed in that, and so graciously just gives it away for free. All the years of his
Yeah.
experience. So we'll make sure that we can provide that for folks that want it. If
Yeah.
you email us, blairchiropodcast@gmail.com, I'll make sure to get that in your hands so that you can start using it as soon as possible, because it's highly valuable. Anything else that you'd like to share sort of on the communication management side of things as you're thinking about that whole concept?
Yeah, one of the big concepts, and this is good for new doctors or students, and I think it's a common mistake that new doctors make. This was ingrained to me, from Dr. Schulten. That is just a huge concept, which is the P of the SOAP note. Do you know what P stands for?
The plan.
The plan. The plan. How many of us, when we're starting out, do not communicate the plan to the patient all the time, right? I remember when he was first telling me, like, listen, you got to hit that P, all the time. And I'm like, so you mean like on the reeval? He goes, no, every visit you are hitting the P, right? You have to contextualize where they're at, every visit relative to where they started and where they're going, right? And that's where the plan comes in. So every visit, they kind of have to know where they're at in that journey, where they're at in the story, right? And that was a huge concept for me. And I would see, and even now, like, what was it? Last month, I had someone kind of drop out of care after a couple months. And I'm like, I thought to myself, God, you know what? Last time I saw him, I did not hit that P. I was not clear enough with the plan. I was rushed, whatever. But I think that's really important when it comes to communication, is they always have to kind of know where they're at in the story. And then they can, their engagement level, I think, will go up.
Yeah, I really like that. I think it's something that I almost accidentally started doing with folks, just letting them know, hey, you're, for where you are in this process, you're right where you need to be. This is only your second adjustment. You've held the first one for X amount of time. That's really great. I'm pleased with your progress. Let's stick to the plan, and this type of thing. Because I think, especially when you're busy, it gets easy to forget the bridge or the gap that needs to be bridged between everything else that's going on in their life and their few minutes in the chiropractor's office. And while you may see many, many patients in one day, they only saw one chiropractor. And so, it's easy to get lost in the shuffle, understanding, like, where are we? What am I doing here again? Like, what am I feeling? Is this working? Is it not? Do I continue? Do I not? So that's a great point to underscore. And hopefully, folks can sort of introspectively think about how they're doing with that, do a little self-assessment, and then start working on that with your patients and see if it increases your compliance or engagement, because that's ultimately going to converge on better results for them. And so again, it's all about the patient having the most positive healthcare experience, with an upper cervical chiropractor. I like to say that puts points on the scoreboard, for us, and everything we can do to kind of, tally the board. That's good stuff.
Yeah.
Awesome. Do you have any opinion or school of thought on the integration of full spine within an upper cervical model? I know that's something that when we sort of gauge questions, a lot of folks want to know, they want to peek behind the curtain and see, like, are you guys actually doing
Yeah.
lumbar rolls in there? What's going on? So not to get anyone in trouble or to step on any toes, but just curious if you have a thought process behind when you would integrate versus refer that type of situation, or if you even see a need.
Yeah, I mean, you have to have a plan, I think. It seems like, some doctors are, make a very clear line like, hey, I'm only going to adjust the upper neck. That's it. Dr. Forrest, for example. And it works great. For me, the way I do it is I focus the first month on exclusively upper cervical, and hopefully the whole time on upper cervical. Like I don't want to introduce anything else, but if I feel like there's something that's relatively easy that I can do, to where they don't have to go to another office, whether, I have a full spine drop table where I'll do my leg checks. If I'm just going to adjust an sacroiliac joint or sacrum or kind of a mid thoracic, very sparingly, I'll do it. Just if but the key obviously is I don't want to interfere with the body's adaptation process. I mean,
Right.
that's the key. And that's why I wait a month. I mean, I'm not going to do that in the first month, because I want their body. I want to see how much of their body, responds. And the way I communicated that is, listen, I have a strategy here. We want to give this a month. If your body makes the changes without me having to do it, it's going to last a lot longer.
Mm-hmm.
And most of them get that. Sometimes what I'm doing more lately, I have an arthro stem, and so I'll do like some trigger. There's a trigger point attachment. It's almost like one of those Theraguns,
Mm-hmm.
you know, um, where sometimes we'll kind of loosen up the upper trap or the rhomboids, and then do before their upper cervical adjustment, and that seems to help, especially people who are sitting all day and just have that repetitive stress, poor posture. Just doing a little bit there, they seem to just like that, something's being done, and then kind of focus on the main event, which is the upper cervical work.
And I think most folks will appreciate that you're not trying to make them dependent on someone treating them all the time. And so if you
Yeah.
can kind of paint it in that light, it's like, hey, we want your body to be, because it is a self-correcting system. We want your body to fix as much of this stuff without intervention as possible, so as to not become dependent, on someone frequently mobilizing your spine just to maintain a level of relief. And we don't want to slow down the healing process. So I think folks are reasonable. I think folks will gravitate towards someone that is honest and in
Yeah.
communicating with them in integrity and telling them something that doesn't sound like a line of BS, but also addresses their concerns, because it's our job to, ultimately provide the care that they need. And sometimes folks, want things that they don't need or don't want what they do need. And so it's, a process of navigating them through that journey as they go through.
Yeah. And just understanding, that you can't be everything to everyone. That's just not realistic. No one is. And so understanding kind of where your comfort zone ends and kind of having some rules for that. I mean, I probably refer to other chiropractors more than anyone else, in my area for sure. I don't want to, I'm hoping to get them everything they need here, but I'm a big fan of professional referrals and developing those relationships. So, it's good to incorporate massage therapy or acupuncture. And then, you're getting those patients back too. You have those relationships. And then just building integrity, like you said, being honest with the patients. I mean, we should all be playing the long game, right? We should not just be thinking about, how do I get you more visits, or how do I get you to come back? Like, I want you to know that I'm awesome at what I do, but if it's outside of my zone, I'm gonna be honest with you and tell you. And then what you find is that's the reputation you have in the community, right? And they'll send you other people who they know you can help that may not be, their particular need, right?
Yeah. Yeah, absolutely. Yeah. And especially when you see folks that have been to 3, 4, 5, 6 other chiropractors, they've kind of hopped around and tried a lot of different things. I think it's important to kind of have the conversation up front, like you were talking about. Here's the plan, here's the expectations, here's how we do things, and not get tempted, to try to, over deliver under or that kind of thing. There's a temptation to want to be, the best possible experience that they've ever had, and that kind
Yeah.
of thing. So don't do like I did. I was baited into a situation with a patient one time who, yeah, I think it was like 3 months into practice, transferred from another, Blair chiropractor, had been under care for a long time, and started telling me about, well, he would always do this thing when I was holding, or he would do that type of adjustment. And, to make a
Yeah.
long story short, I got myself into trouble, chasing a symptom with a patient, doing lower spinal stuff that I'm not qualified to do. If I'd have just talked to the chiropractor in the first place, he wasn't actually doing those things with the patient. And so, I think especially early on, you want to be liked, you want to prove yourself as credible, you want to keep the patients, long enough for them to get the results that you want. So don't be tempted, trust the process, and make sure that, like we talked about earlier, you've worked through the system in a way that, gives the proper amount of time, to see the result that you'd expect. And time after time, when we have these conversations with docs, especially ones that have been practicing for 25 years plus, they always, have advised us to be conservative. When in doubt, do nothing or less,
Yeah.
and always get back to the basics, and always stick to the tried and true principles, rather than overcomplicate the situation. So that's something that, I try to keep in mind, because it's easy to, in the moment, think that, more or a more complex solution is going to be better.
Yeah. And understanding that a lot of times what they need is not an adjustment, or, whether that's upper cervical or elsewhere. What they need may be, reassurance, or what they need may be a specific exercise or specific advice on, hey, tell me how you're sitting at your computer. Like, walk me through that. Like, where's your screen? And then you kind of uncover things that, hey, this is why your low back hurts. Like, this is what you need to try. So it's not always the adjustment, even though that's kind of our default, is we want to be able to give the adjustment to solve XYZ. Sometimes we just need to, investigate a little further, ask more questions, and understand that we can give value without always that value being the adjustment itself.
Yeah, and actually, I think you can run the risk of devaluing the adjustment by trying to use it for every little
Totally.
pain, or thing like that. When it's, there's a lot of, I know Dr. Brooks, who does the Taking Care of People seminar series. I've
Yeah.
not taken it, but I've heard various clips, and he talks about issues in the tissues, and rates of recovery, and things that affect, the progress that folks make, and things that are related to or not related to their spinal misalignments. And I think all that really makes good sense, and creates boundaries around, what it is that you have to offer, and puts you in a position to help the patient succeed without, without having to flip yourself into a treatment-based model where an adjustment is a solution for every little, health challenge.
Right. Totally.
Cool. We talked about this a little bit, but I know that you kind of had a background outside of chiropractic in, a tech startup in that sort of world. What's the business of upper cervical care been like for you over the years? I know you've had a few different roles,
Yeah.
as either an associate or a contractor, and then starting your own practice. So walk us through your evolution as a businessman, and within that aspect of practice, because it's, something that's unique, within certain healthcare fields, that we have to wear this other hat, which is, entrepreneur, small business owner. So could you share
Sure.
some of your lessons or your experience from that side of things?
Yeah. I mean, two of the biggest lessons that I'll tell, new docs who are starting their own practice. Well, actually, three lessons. One is, when you're talking about hiring people, and this is just a business concept. I didn't make this up, but you got to hire slowly and fire quickly. I've made the mistake of hanging on to, my CAs just too long. And it really affected my practice. There was two cases where I did that. Right now I have a great CA. She's probably a lifer. I hope so, knock on wood. She's been with me 3 years now. And she's great. And I was really patient on hiring her. And so I think that's a big concept, is, whether you're hiring an associate, whether you're hiring a CA, hire slowly, take your time, because if you hire the wrong person, it's just going to set you back, immensely. So that's a big one. I made the mistake when I first started the practice of I think spending just too much on advertising. I kind of had the philosophy at the time that I'm going to try each thing and just see if it works. Try, at least for a reasonable amount of time. And I was just throwing money away in the beginning, stuff that just didn't matter, like print ads or, logo t-shirts or whatever. I mean, your logo t-shirt's nice, but I overbought stuff that I thought I was going to give to practice members that no one really cared about, and stuff like that. So you just have to be careful. I mean, I think when you have more time, when you're starting a practice and you have more time, I think using that time to really connect with people rather than just using your money. And then I think the big thing now for me, as I've transitioned to where I'm busier than I've ever been, I really have learned to say no to things. That's another common concept. I mean, I have two young kids. My wife works full time. I just sometimes get myself in situations where I'm committing to too many things that are not really driving my core purpose, a core business. And I think I see my business suffer and my practice suffer when I'm kind of over my skis a little bit, and too kind of outreached on stuff that doesn't really matter. So I think just being able to say no, focusing on what matters, I think that's something that I've learned.
Do you have any tips for sort of work-life integration and sort of developing a balance between being dedicated and committed to the growth of your practice, but also, there with your young family? Because I know for a lot of folks, especially when they're sort of in the earlier stages of practice, they're also in the earlier stages of their family life. And so there's two different forces that are kind of pulling at them that they want to invest in. Do you have any tips on managing that seesaw?
Do you have tips for me? I'm still looking for tips.
That's why I'm asking, brother.
No, it's tough. I mean, it obviously depends on your situation. I think for me, when I had my daughter in 2014, I was already, 2 years into my own practice. So it wasn't like I was doing both at once. I think that would be the hardest. I mean, you definitely want to establish kind of a base. And then, my wife does work full time. So, that's something that it's not like she's just available to do everything. We really try to split things. But I think just the best advice is just to, like I was saying before, is to be able to say no and really understand what are the things that I can do that can directly, help me on a personal level, like on a personal growth level, or directly, relate to the business growth, and understanding what those are and only focusing on those.
Yeah, shout out to all the chiropractic spouses, partners, significant others, that kind of journey with us through all this, because they really are, sort of the foundational support system that allows us to do the stuff that we do. And I know for a lot of us, it's like the almost unconditional support that we get, is fascinating, without being a chiropractor. Sometimes these significant others and spouses get the big idea, quote unquote, and are just all in. So I appreciate, all of you that are listening. Go home and hug your wife or your husband, or take them out, do something special, plan a long weekend, because there's a lot that goes on behind the scenes to make sure that you can keep doing your thing.
For sure.
So as we start to round the corner here in the conversation, you mentioned your philosophy course with Dr. Sean Dill, and sort of the role that the chiropractic philosophy had in sort of navigating you through to where you are. Where do you see chiropractic philosophy fitting into practice? And do you have any, any sort of grounding philosophical concepts that you kind of come back to help keep you focused and on track?
Well, I think one of them, I mentioned, which is just being comfortable that you are a specialist and that you don't have to be everything to everyone. Being comfortable that there are outside influences that affect how someone heals that you don't have control over. Right? I mean, this issue of control, I mean, I would drive myself nuts because, and I'm sure everyone can relate to this. You see 30 people in the day and you're not thinking about, the 15 to 20 people that are doing awesome. You're thinking about the 2 people that are struggling, right? And you take that home with you and you're like, God, what did I do? Did I mess up that adjustment? Maybe they were, I should have left it alone last time, or, what's going on with this case? And it's oftentimes completely not related to anything you did, completely out of your control. And it just, it's something that you kind of have to recognize, right? Like, we're facilitators. Like, one of the things that I've always thought is, and I don't know if this is a controversial topic, but I don't think chiropractors should be primary healthcare providers, because it's completely against the philosophy of chiropractic. We should not, primary healthcare providers, the number one responsibility is diagnosing and naming symptoms, right? That's not what we should be doing, right? We're not really concerned with naming a condition or naming symptoms or categorizing something. And I think that's part of what maybe gets some people in trouble, is you kind of go down that road, whereas that's not, we're trying to get to the core. We're trying to get to the root cause of this, and the symptoms are secondary. That's something that will follow what we do, and how we facilitate that. And so that's something that I've always thought about, and I think the philosophy really goes against the grain of the primary health care role.
Yeah, it's a fascinating conversation. When I was at Life University and had Dr. Matt McCoy teaching us some of these concepts and really illustrating the rationale behind the move towards primary care designation within chiropractic, and what that actually means, and where we're actually uniquely trained and where our skills fit and where they don't. It's just such an interesting history. So I'd love to have him on this podcast at some point, kind of walk through some of those details, because like you said, it's very important. And I think, speaking of business, you pick up any business book these days, it's start with why. It's understand your philosophy of why you're doing what you're doing and where you fit into the market and what you have that's unique. And one of the things that I think that's genius about chiropractic is it started with a concurrent philosophy that developed. And I don't know about you, but I found that a lot of folks that have opinions about philosophy have never really approached it or studied it, don't really know what it's about.
Yeah.
So I would say approach it with an open mind, and give yourself the chance to sort of critically appraise it for yourself. Because I know for a fact, most upper cervical folks, if they were to read, volume 25, chiropractic clinical controlled research, and you would understand that, BJ Palmer was talking about spinal fluid flow and blood flow and all these other concepts in the 30s, 40s, 50s. I mean, these are things that he was, a scientist as much as anything. And, there's some very fascinating, scientific concepts that blend in with the philosophy and are really married to it. So I think, it's not necessarily an either or type situation. You can find a lot of congruency between concepts of innate intelligence and what we understand now about neurophysiology and how the body adapts to stress and, in its environment and all these different types of things. So, I would just encourage folks to just, pick up a green book. If you don't like the way BJ Palmer writes, I know Dr. Rob Sinnott put out his textbook of chiropractic philosophy and his textbook of human adaptability. They're phenomenal and really kind of take a, modernist look at some of those concepts and deconstruct some of the language that folks trip over, like things like dis-ease and stuff like that. So yeah, definitely think it's an important thing to approach. You may find that it's not for you, and that's okay, but I think it's worth exploration.
Yeah, and how to communicate that philosophy to patients in a different way than you're consuming it, right?
Yes. Mm-hmm.
Like if you just kind of regurgitate BJ Palmer's words, it just will it won't hit the way that it needs to. So I think kind of being able to filter through that and kind of repackage it.
Yeah, that's another great point, because I've always been a little frustrated with some of the folks that um, are really strong in talking philosophical constructs, but then the clinical care is a little bit haphazard, in my opinion. And I've always
Yeah.
thought like that's not an equal footing, and so I think that in upper cervical, we're in a really unique position where the science and the philosophy and how we apply it through the art is extremely congruent. And we do have a way to make those concepts real and practically, relevant to the patient. I think it's worth, like you said, it's worth internalizing and finding a way to connect the dots between patients, because I think a lot of folks are looking for, a different way of thinking about health, and we actually have something to offer, which is, extremely simple in its core tenets.
Yeah.
Awesome. Okay, great. I'd like to add a little value for the students here. We kind of touched on some of the different things to think about when navigating the technique world. But do you have any advice for students as they're, kind of approaching the end of the curriculum, they're evaluating their next steps or their career options? Do you have any resources or tools that you'd encourage them to, pursue in order to kind of make the transition from a student to a doctor?
Yeah, I mean, I think there's a lot of value in um, spending a year or two or whatever, in someone's office learning, earning a paycheck, but learning. Nothing can substitute experience, right? I mean, nothing. You can't learn anything in a seminar that will be greater value than actually seeing patients, and digging into cases, and understanding the business concepts and how a practice works. So I feel like that's always my advice is, for me, working in someone else's office for 15 months, that was critical for me because I could just hit the ground running when I opened my own practice. Not everyone's on that path, and if you're not, then I think spend as much time as possible observing practices while you're a student. Resources. I know there's a couple chiropractic groups that help kind of doctors make that transition from student to practice. Like AMPT is one of them, for example. That just they have systems in place, and kind of it enables you to when you're opening your doors, you have new patients waiting and you have systems in place and all those things. But I think the observation and the learning from successful doctors is like that will exponentially change your trajectory. Just kind of sacrificing a year or so in the beginning, and then you're just going to be shooting ahead of your peers who didn't do that.
Yeah, that's great advice. I know it's just a huge disconnect between chiropractic academia and what actually happens, in the real
Oh,
world day to day. So I think it's, definitely worth your time, even as a student, or if you're, postgraduate in between, opportunities, just be in different settings, in different sort of practice models and that sort of thing. I don't know, there's something about aligning yourself with folks that are doing something that you think you'd like to do, even if it doesn't work out to be
yeah.
exactly, it at least puts you on a path to pivot and make transitions and sort of go from somewhere. So good advice. I wish I would have followed it when I opened, but I'm the bullheaded type that has to figure everything out myself. So as a almost, I guess I'm almost 4 years in at this point. I'm actually doing more of that now than I did, as a student, because you find so much value in others' experiences. And I will say within the Blair community, there's a extreme openness, that I've encountered. When you have questions, concerns, their docs are very eager to help.
Yeah.
Folks are not unapproachable. It doesn't matter who they are or what they're into. I think if you do reach out and you're eager and you're humble and you really want to learn and do better, there's an endless amount of resources to be able to help you find your way. So I would say, as a student, get connected with the Blair Society or a technique organization that resonates with you, and just get plugged in. It's not a hard thing to make those initial connections. And so that's how you and I met. And there's countless other docs that, I'll ping questions on them. You kind of figure out who's into different things and where to focus in. So if you've got questions with imaging, you're going to go to Jake Hollowell on the CBCT side of things. If you've got
Yeah.
questions with business or practice management, there's a lot of folks that have been trained by guys like Dr. Lenars and Dr. White that have a really, really savvy sort of business acumen. So there's a variety of different resources. So don't feel alone and don't struggle needlessly. There's a lot of folks that are willing to help, and a lot of DCCJPs, a lot of diplomates within the Blair Society too. So on the clinical side of things, very, very high level providers across the board. So awesome. Well, no, I appreciate the generosity of your time, and I know that you're doing a better job of saying no to things that you don't find value. So it means a lot that you were able to join me this morning and talk a little bit about all this stuff. I could go on and on because I'm just so fascinated by all the things related to Blair chiropractic. But as we wrap up here, is there anything else that you'd like to share with the audience? Any last words of wisdom or anything like that?
No, I think as things approach more normalcy here in the coming months, I think we have a Blair conference in October in Dallas, and I think if we can get students there, if we can get all the Blair docs and really come together after this weird couple years that we've had, I think that'd be great. It's something I'm looking forward to, and connecting with everyone. And I know, like you said, there's a lot of things coming in terms of research and on the Blair board that projects you guys are working on. There's also it just got announced, there's a upper cervical symposium that's going to be in Nashville in August. I think it's, the second weekend?
Something like that. Yeah.
Yeah.
Late summer. So shout out to Dr. Bulow. I mean, being president of the ICA's Council on Upper Cervical Care in the midst of the pandemic's no easy job. So I know that he's done everything he can to try to continue to bring value in that arena. So check that out. I'll add links to all these types of things in the show notes for the show there, or on the YouTube comments here, so you can just access that stuff readily and be able to see what we're talking about. But yeah, that's a great opportunity to be in sort of rubbing elbows with folks from other techniques too. And speaking
Yeah.
of Dr. Schulten, I met him at a Blair conference a couple of years ago, and here he is, a high level board certified NUCA guy, and he's practicing his toggle and going through, learning the different Blair procedures and things like that. So actually practicing what he preaches, which is, bridging those gaps. So it's a great
Totally.
opportunity to get to be around these folks socially too. And there's a lot of great people. We have so much in common. We have a unique way of looking at life and practice that I'm always just really built up, when I'm around upper cervical docs, because it's like you're people, people that get you. So
yeah, and you're constantly taking things. Like I'm constantly, there's a gem here or a gem here with the conversations I have, or ways that people, things that they do in their practice that I'm like, I'm going to start doing that. That's awesome. And that's probably maybe the biggest value for me of going to these conferences and the diplomate program itself is the conversations, the interludes, as Dr. Schulten will say, the conversations kind of in between the curriculum where you're learning how other people do it, you're sharing ideas, and then you're incorporating those, to your own practice. And it's a constant evolution. I'm constantly changing things, revamping, tweaking scripts or changing different procedures, in order to make things better. And I think that constant, improvement, I think there's a lot of value when you get together with other doctors who are really successful and doing different things, and then start to absorb that knowledge.
Yeah, 100%. And currently, where can folks get in touch with you if they wanted to reach out or just follow up and connect with you?
Yeah, Facebook, Noah Kaplan DC at Gmail is my email address. I don't know if you can add that to the links.
Will do.
But yeah, I'm always happy to talk to people. I'd love to, in the next year, hopefully I'd love to get another doc in here to join me in practice. So that's a goal of mine. But yeah, thanks so much for having me. Always a pleasure to talk to you. I know we could probably talk for a couple more hours.
Yeah, 100%. We'll keep it short and sweet for the folks that are watching here and continue the conversation offline. But thanks so much. And if you guys want to get connected with Dr. Kaplan, you now know how. And if you want to meet him in person and discuss career opportunities or even just some of the things we talked about, we'd love to see you at the Blair conference this October in Dallas, Texas, and we'll be face to face. So appreciate your time. We'll talk to you soon.
All right. Thanks a lot.
You got it.